Like, I feel like I sent this article to so many people that I lost where it was.
Oh yeah, I kept going back to the text message to pull the article up.
That's what I'm saying.
And then I had to get through the paywall and log in to my institution login, and then yeah, it was a good article. While you pull that up, welcome back to the podcast. You know, every month I try to do an episode focused on medical ethics, and so fortunate, Dr. Italo Brown, emergency physician, he actually hit me up. He's like, dude, you gotta check out this article. We gotta talk about it, and it's something that I know he is very passionate about. If you don't know Dr. Brown, Italo, he's passionate about public health. He earned an MPH. He went to, he is a son of Morehouse. I think it's what y'all call yourselves. He went to Morehouse College, then got his MPH. Then he went to Meharry Medical College in Nashville for his for medical school. Then went to Montefiore, however you say that, in New York.
You got it.
So a man of the people, and then went out west to, he went there for a emergency medicine residency. Then he completed a social emergency medicine fellowship at Stanford. So my man's not new to this. He's true to this. Always a wealth of knowledge. We could fill this entire episode talking about the stuff that he does to advance the cause, to save lives, in addition to working as an emergency medicine physician. But Dr. Brown, welcome back to the show. So good to have you on.
No, it's a pleasure to be here. And I just love what you are doing here with this podcast. I think it's extremely dope. And I think that it's a wealth of information for folks who are trying to pursue medicine and be better at it.
Awesome. And your podcast, you've been well sought after on in the podcast realm too. I saw you recently recording with some big time shows, and you're doing your thing.
Man, I appreciate it. Just glad to be here and be useful.
Dude, what grabbed your eye? So I was sitting there, you sent me this article. It's entitled Disparities in Unilateral Do-Not-Resuscitate Order Use During the COVID-19 Pandemic. How did you come across this article?
I have to give credit to a good friend named Minerva. Minerva is a surgeon in New York, and we're in a large group. All of us participate in Tour for Diversity in Medicine, a group that was started by Cam Matthews and Alden Landry. But essentially, we share interesting things. And she came across this article and dropped it inside of our group chat. And maybe because I was just awake at that time, but when I saw it, I was like, this can't be real. And then I started going through it and I'm like, this is actually kind of horrible in the sense of what it means for patients from specific subpopulations. And so she is a Latina woman and identifies as such in her field, which already makes her a rarity. But this is an issue that should be relevant to anyone, no matter what their frame of identity is, because anytime you're having disproportionate loss of life, especially during a time where we already assume that, minoritized groups were disproportionately affected, this is significant for us to know.
Yeah. And this paper came, you sent this to me as well as a bunch of other people. I love medical ethics, and I expected this to be the usual, man, Black people have worse outcomes. And I was very surprised by some of the findings of this paper.
No, I agree. I assume. So I always assume the worst, which is kind of a bad thing. But I'm like, all right, so there's going to be something that says Black people are dying at a disproportionate rate. That's just what medicine in America has come to. But to hear that there was another minority group that was experiencing worse outcomes related to this particular identity issue, or not identity issue, this particular variable, I thought that was like really, really fascinating, and not from like an ecological, like, oh, I'm learning a lot from this, but really, are we missing the ball on some of our diversity, equity, inclusion, and health equity conversations and metrics? So, I keyed into it, and it was definitely something that was eye-opening.
So to get everybody to the same kind of baseline, a do not resuscitate order is something that can be placed in a medical record by default. If you come into a hospital, you have a cardiac arrest, they find you on the street, wherever, we're going to try to resuscitate you. We're going to try to restart your heart, do CPR, place a breathing tube, all of the above. We've chosen to default to that as a society, and you have to opt out of that. We say, hey, For whatever reason, there's little chance of um, uh, uh, recovery. There's little chance of living a meaningful life as you interpret it. For whatever reason, do you want to be resuscitated? Some people, maybe they have terminal illness of some sort, would prefer not to be resuscitated. So there is that standard kind of conversation that we have with patients or patients' surrogates to talk about their wishes and not resuscitating them in the case that their heart were to stop. Now, so explain the difference between that standard DNR and a unilateral do not resuscitate order.
So from what I understand, like a unilateral do not resuscitate order essentially is the same thing as a DNR, but it's placed by clinicians. And they don't need any type of consent, any information from a parent, from a surrogate, some type of patient. It's something that they can just clinically determine. And this is something that has been around for quite some time, right? I think one of the times where we started to hear about this more commonly was in the beginning portion of COVID. I think there was an article that came out of Boston, like an op-ed piece talking about how hospitals are coming up with their decision trees to make these unilateral do not resuscitate orders. They were using different metrics like, kidney function and comorbidities and all these other things. And it was initially thought of as a way to kind of further, exacerbate known disparities in terms of healthcare outcomes. But it's, to me, very fascinating because what people are saying is like doctors are trusted with the ability to make like clinical reasoning and the judgment on whether or not you can cease resuscitation orders just by your own belief system or your own algorithm.
Yeah. So as an anesthesiologist in residency, I did like 6 months in the ICU as a resident. I've come back and I'm doing an ICU fellowship. So I have personally placed several unilateral DNRs. We'll talk about this a little bit in the paper. There's different institutional policies with that regard, whether it takes one physician to do that, whether it takes two physicians, whether it takes an ethics committee meeting. But there are situations that are so dire that this patient has no meaningful chance of recovery, and there's no family members or surrogate decision makers to talk to, or maybe the family members or surrogate decision maker says, I still want everything done, and it gets to a case where it is physiologically futile care to continue to provide resources because we do live in a kind of a resource constrained environment. So there are legitimate cases for unilateral DNRs, but it's interesting because of those healthcare disparities you mentioned and the time frame of this study, which coincided with the COVID-19 pandemic.
Exactly. I mean, most of the time people try to think that we're doing the best that we can. I think the hard part was that during this time frame, we were already seeing health disparities essentially swept under the rug.
In real time.
So as you started to question whether or not there were already known like disparities, did something like this exacerbate it even further? And so, hindsight, we're able to kind of look at this, and that's what this team apparently did, was just look at a bunch of different data sets and see if there was any pattern or trends that emerged.
Yeah. You want to break down the study, what they looked at?
Yeah, no. So essentially what their goal was to look at these ICU stays, patients who were admitted to the ICU. They had a defined time frame, and it's actually pretty fascinating, like April from 2020 to 2021. And there's these two hospitals where they looked at these ICU stays, every single type of ICU, and tracked what those, do not resuscitate, or they call them UDNRs. So these UDNR orders. And then I just looked at a bunch of demographics, things that were reported, or different identifiers that were aligned with those orders.
Yeah. So they looked at a couple different institutions. They got kind of they weren't able to get a hold of the institutional policies for how to invoke a unilateral DNR. But like Italo mentioned, they looked at the demographics. And man, I always kind of zone out if it's like a study that's done over 10 or 12 years. So the fact that this was a year, it was in the heat of a pandemic.
Yeah.
Like this is like almost real-time results we were watching, right? Remember that time, the Black Lives Matter movement, the healthcare disparities in real time. So to look back at like what clinically was happening is fascinating.
One of the things that I thought was really fascinating about kind of their design or their way of looking at these outcomes was not only did they capture like demographics of the patient who the order was placed on, but also who placed it. So like,
Yeah.
what were the demographics of the clinician? What was their specialty? What was their documentation like? Like those things to me are really fascinating, especially when you're trying to infer if there's some sort of connection, association, or pattern.
Yeah, the study looked at 2 hospitals. They had greater than 100 ICU beds, large hospital systems, and they included people or patients that were sick. They were on vasoactive medication to maintain their blood pressure, and they chose that to select for very sick, critically ill patients. So they didn't specifically look at the COVID-19 diagnosis, which I think was a good idea because that would have introduced a lot of other kind of variables, because there was in the beginning, do we have tests to enough tests to actually diagnose COVID? There's a lot of other variables, but it just looked at critically ill patients that were admitted to these ICUs during this time who were on this maximum life support, because for a unilateral DNR to kind of have to be legitimate, it's kind of saying we've exhausted all medical options and therefore we're not going to resuscitate.
Right.
Yeah. So then you want to talk about the primary outcomes and what they looked at in this paper?
Yeah. So what they did was they went back and looked at the EMR to define whether or not there was an order placed, and then was that order documented specifically by clinician judgment, as opposed to it being like a decision made by the patient or by a family member or some other surrogate.
Yeah, the characteristics of these patients. So there were just over 3,000 patients admitted to the ICU during the time period the study was taking place. They included 1,473 patients, so about 47% of that initial group. They were included in this analysis due to their high severity of illness requiring vasopressors or inotropes. And then during the hospital admission, 41% of patients included in the study had a DNR order placed, and 3% of the patients had a unilateral DNR order placed. So an N of about 51 patients. Now, what did they find? This is when the rubber hits the road.
This is kind of the messed up part, honestly.
So
yeah, go ahead.
Yeah, so so what they found, the patients with a unilateral DNR order placed were predominantly male, 53%, Black, 47%, English speaking, 63%, insured with Medicare, 43%, and had median age of 64 years. Now, Italo, you have the MPH, you read these papers for fun. The percentages, the raw percentages don't really tell you what's going on, right? Because that's the big number.
Right.
You got to do some other permutations. Can you explain, like, how do you get to the actual signals?
Well, what they're looking for is not just ranges, but significance in those ranges. And I think that what they're really trying to identify is it a statistically significant amount of people where this is occurring? And their p-values are pretty good when you look at that. So I think a few of the p-values are like less than 0.005. And so to me, that means that it is highly likely that this is not due to chance or randomness. The other thing that I noted is when they're looking at these particular, hold on, let me go back. So when I looked at the numbers, essentially what I was trying to see was, were they high enough to even tell if there was a difference? And so they checked that box. Then it was, are the p-values in the range where this could be considered not a random occurrence? And they checked that box almost in every single one of their multivariate analyses, right? So I think that that's good to see. And then it's just like a strong, I would say, comparison to use these very well understood, very clearly defined demographics and to have enough of that data represented in the charts. So it's not like you're missing a bunch of information. It's like, no, this was actually captured and they did it prospectively. So when you're looking back at it retrospectively, it's pretty accurate.
Yeah. Yeah. So the actual data, the odds of the unilateral do not resuscitate order by patient characteristics, I mean, this paper, I'll put a link in the show notes. It goes through age, sex, male versus female. It's pretty equivocal. When it gets to race, ethnicity is where that first kind of signal starts to pop out. So compared to with the odds ratio, Black or African American, odds ratio of 1.9, so almost twice the risk. And correct me if I'm interpreting this incorrectly, but the odds ratio was 1.9 for Black or African Americans and 4.1 for Hispanic or Latinx patients.
That's correct. One thing that I do want to emphasize for people is like the fact that this logistic regression analysis was used, right? So you're really looking at probabilities, like the likelihood of this probability being due to pure chance or something that is not just by chance. I think it was an excellent choice in terms of analyses to use to try to like elucidate this a little bit further.
The next thing they looked at language, right? Which is kind of crazy when you think about it. It's 2023 when we were talking and recording this. The healthcare disparity for non-native English speakers. So the odds ratio, right? English speaking being 1. If you were Spanish speaking, your risk was 4.0, like 4 times that of a native English speaker.
Crazy. I mean, if that does not jar some type of emotion from you, I don't really know, what your compass is, your moral or ethical compass is, because just to hear that there was that order of magnitude, like not just like 50%, it's 4 times, that's terrible.
The other thing, like it just, popped out to me. This isn't the big signal from the paper, but looking at insurance status, I think people overlook the impact insurance status has on your health outcomes. So if you're private insured, that's the odd ratio of 1. Medicaid 1.5. Medicare was about the same at 1.1, and then uninsured almost 3 times the risk of having a unilateral DNR order. And then if you passed away during admission or discharged at hospice, then it had almost an 8x increase in your risk, obviously, because you're getting a unilateral DNR.
Yeah, I struggle with it because, I mean, we'll get to the inferences in a second, but it's hard to look at because you're saying to yourself, all right, there's got to be a mistake in the data. There's got to be a mistake in the way it's captured. These other factors have to have some sort of like convergence, or there's maybe like an error, some type of other statistical error that exists. And to be honest, the authors of this kind of like did a pretty good job of, trying to eliminate as many types of error as possible. So it's like, no, this is actually it.
Yeah. And to remind you, this is 2 different hospital systems that they're looking at. At the end, they kind of broke down hospital A versus hospital B. And hospital B had 4 times the risk of a unilateral DNR order being placed. And I don't think they identified, the hospital. I doubt they would do that. But so again, they just showed the difference in how 2 hospital systems kind of manage this.
Right.
And correct me if I'm wrong. I don't know if that, did hospital A maybe have a different demographic of patients, and I don't know if the analysis.
I don't think that they
part.
No. So my suspicion, I don't know if the hospitals outright, but my suspicion is that information is somewhat protected on the strength of maybe the profile of the hospitals that are involved. And I will also suggest that as people ask more questions around this paper, I think those details are going to be requested. So, once this starts to really circulate, I think that there's going to be a letter to the editor where it's going to provide more details around this, because that would make a significant dent in understanding the underpinnings for this, the differences that we see. But you can make some inferences, right? It's like, all right, how many percentage of people were documented as Spanish speaking or not English, having another first language other than English in this study? And as those numbers go up, you can kind of think about where in the city these would be located. So like proxy measures of it.
Yeah. Hablas español.
There you go. There you go. There you go.
Right. I've been learning Duolingo for about 5 years, right? I've been working on my Spanish, and my wife laughs at me because all I have time to do is like the quick lesson, which is like, hola, mi caro es rojo, you know? And she's
Right.
like making fun of me. So this hit home for me because it's like, how often do I have a Spanish speaking patient? And as a Black man, physician in America, like I understand the ramifications of healthcare disparities. And sometimes I'm still rushed to take that time to actually get the interpreter phone or to go 100% to make sure that I am providing that same level of care.
No, that's the right way to approach it. I think what I learned out of this is, I work in California and our Spanish speaking population is pretty high. And I always think about engaging an interpreter, but there are some facets to this that, interpreters don't necessarily get, there's like family dynamics. There's other elements, people not feeling comfortable enough to speak up or share their information, whether there's an interpreter there or not. So I think that, it's one thing just getting over the pure barrier of language, but culture, practice, identity, like all these other things get drawn into the spectrum, and they can significantly impact or influence someone's ideas around do not resuscitate orders, specifically how likely they are to speak up against it. You know what I'm saying? Like, even if it's a unilateral DNR that's created, but their ability to advocate and raise hell, that changes.
They mention, and I'm so glad they brought this out, past studies have found inaccuracies in interpretation of medical content by medical interpreters. 25% of the time with interpreters by video conference, 23% of the time for in-person professional interpreters, and 54% of the time for ad hoc interpreters. That's when you grab the family members.
Major point there. One thing I wanted to point out from that as well is that, like, we're talking about a time in COVID where we were not even sending people into the rooms. You know what I mean? So it's like, how are you having this conversation when the interpreters at the time were worried about their own safety? So you're using more telehealth or telemedicine tools. And so this is something that also has to be explored. Like, how was this occurring, and who was physically present? So.
Yeah, they brought out the fact that in the pandemic, which highlighted these healthcare disparities, they say one reason or one potential explanation that primary Spanish speaking patients had higher rates of unilateral DNR placement is because they also had higher rates of COVID-19. I remember, we saw this happen in real time. We talked about these social drivers of health, I think is what is the proper terminology.
I see you've been learning and reading.
Bro, you've been posted.
Yes, sir. That's awesome. I mean, these are the things that are going to be, like, if they continue to do analyses outside of this one particular one and see other factors, like really look at this population or subpopulation, they're going to see overlaps with these social and structural drivers of health. One indicator is obviously insurance status, but I think they can continue to see like socioeconomics, geography, like all these other things. But it's really fascinating to me that this study, hasn't really bubbled to the point where it's like a lot of people frustrated. Maybe it's because it recently came out, but I think that this is, it's very much so. It speaks to something that was happening in a variety of other pockets. Like, okay, we have this data set, this group that's out of Chicago, which if it's occurring in this type of a environment where we tend to see healthcare elevated, imagine what's happening in some of these other locations. I mean, what if this was Texas? What if this was Georgia, areas where they have high Spanish speaking populations and don't necessarily activate some of the services that would be more likely to be activated in Chicago. So,
yeah, I should have put this disclosure in the beginning. I may go back and edit it, or probably not. But I do work with several of these authors. I did a fellowship in clinical medical ethics. They're part of our ethics fellowship program. And so I just like kudos to them for pulling out these signals in the data, thinking about this study design and bringing these issues to the forefront. As a Black physician, I
Right.
mean, this is eye-opening and encourages me to change my practice.
Right. Right. And it's very bold, and I don't know what this will bring for that group, but I do think of it as a necessary step. And so I'm glad
Yeah.
that they published it. And I think it's extremely impressive for them to risk, whatever comes with this, to really give light to something that is true and eye-opening and incredibly powerful. As a Black clinician, what this says to me, and this is the real funny thing here, is that I know your typical podcast listenership may be skewed slightly, maybe towards people who identify as Black or African American or of African descent. But this is important for us, not just as people who can be intersectional, but really we might be the only ones who can advocate in those situations.
Right.
If the number of Spanish speaking clinicians isn't increased, or if they're not present, like, you should be able to advocate similarly, or at least be aware of it. And so that's something that I took from this, is like, hey, as the Black doctor, I should be thinking about this type of stuff for all of the populations that I see, because I understand what it happens to people who look like me, And so it was very, it was soul stirring, and I felt where they were coming from.
Yeah, man. Well, I am glad you saw this and shared this article with me. I'm glad Minerva shared with you. You said there was a Tour for Diversity connection. I got to plug the folks at Tour for Diversity. They're doing an incredible work of this mission of increasing the diversity of the healthcare workforce, which would make so many inroads into changing policies and pushing the envelope and creating this equitable space.
That's right. That's right. I mean, the more we get clinicians who are of other cultures, who have other languages beyond English, and who have a robust understanding of family dynamics, will be better at these type of moments. And then there will be a feeling of representation. Because I guarantee, if this information got out to the Spanish-speaking patients that we have, and it was in the language they understood, they'd be raising all hell. And we need to have, we need to be able to produce folks who reflect the populations that we serve, even during the most trying of times. So I'm not going to accept the excuse that, hey, this happened during COVID, we didn't know what we were doing. That does not work. We need to have equity as in the front of our minds at all times.
Oh man, Dr. Italo Brown, emergency physician, bro. Every time you come on, it's good.
Dude, I will continue to show up, and as long as you got this platform and are doing good work, man, I'm super supportive of it.
I appreciate it, brother. I know you got to go and actually save some more lives. Get your hands dirty. No public health tonight, but got to head off to an ER shift, and we wish you well. Get out there and help some folks out.
That's right, man. Trauma shears on deck.
Thank you for tuning in to this episode of Black Doctors Podcast. We're here every week because representation matters.